All right, well, welcome. My name's Clancy. I'm an occupational therapist and certified hand therapist. That's been my background, is treating upper extremity injuries. So for many years, I've specialized in kind of shoulder, elbow, wrist injuries, specifically chronic pain, repetitive stress injuries. With that, I went on and got a degree through the Institute of Structural Medicine and became a certified structural integrator, because what I found treating folks with chronic pain of the upper extremity is I started to see that there were patterns where people weren't getting better, that I could treat them, for instance, for like a lateral epicondylitis or for another condition, and I would get them better, but I'd only get them temporarily better, and they'd show back up with a shoulder problem or a neck issue. And it was like one of those things where you have a gopher and you're trying to, you have the handle trying to handle all the symptoms. So understanding that if I looked at the whole body and the whole system, and specifically fascia, that I could start to understand how to be able to help people better. So went back and got this degree in structural integration, and then came back to my clinic and started to practice more in a whole body kind of way. And with that, found that I could get some really, really great results, and I could create a really nice base of support and be able to make sure that when I got people better, that they stayed better. But there were many people with chronic pain conditions that couldn't handle the heavy-handed structural integration. It was just too much for their systems. And I learned about Bowen work from actually a client of mine who had a rotator cuff problem. And she came in one day and she said, "Look at Kelly, I have full range, I have no pain, I had one Bowen session." And I had been doing very traditional modalities with her. I've been doing ultrasound and electric stim and specific rotator cuff exercises. So I was blown away, and I called her therapist and said, "Thank you so much for helping me, or helping her, and what did you do for her?" And she said, "I just did this new thing called Bowen work. Why don't you come and I'll give you a session?" So she was very, very kind. And so I went to her clinic, and she laid me down and did what's called the basic relaxation moves, which include moves on the low back and into the hamstring and the IT band, up into the upper back and neck. And it took about an hour. And it was really odd, because she would do these very small moves on me, and then she'd leave the room. And then she'd come back in a couple minutes and do these very small moves. And my little Western medicine brain was like, what are you doing? And I literally found myself wanting to figure out how I could flee, because I thought, this really is a bunch of hooey. This cannot be doing anything. So I kept asking her questions as she'd come in, and I could tell she was trying to direct me to be in my body, and I just couldn't. I was in my head. So she was very kind. She said, "Why don't you come back and I'll do another session with you the following week." And I didn't have any physical issues at the time, so it was kind of challenging to feel if it was working or not. But I came back the next session, a week apart, and in that session, I kind of got out of my head, and I was able to just try to be in my body and be present. And what I started to feel was, I could feel there was like pulsing sensations, and there was tingling in certain parts of my body that she didn't touch. And I thought, this is really interesting. Like, something's happening, and I can't physiologically explain what's happening. It's not my heart rate, and it's, she didn't touch me there. So I thought, I'd like to take a class and just see what this is all about. And so I took a Bowen Module 1 class and sat in the back and was like this, and really skeptical. And people in the class were talking about, extreme experiences they had had with it that had really helped them, or people that they had known of that had helped. So I decided, all right, I'm going to suspend my disbelief, and I'm going to take another class and another class just to kind of see. And so I ended up taking the whole series. I went through and took all the way up through Module 7. And at about Module 4, I had switched jobs, and I started to work at Swedish Hospital downtown. And I was part of their rehab department there. And I decided to kind of do my own study. And so I took a group of individuals and I did traditional treatment with them. And I took this other group and I did traditional treatment, but then I asked them if I could add some of these Bowen moves at the end. And so I did, and it was amazing. They came back, and this group over here started to tell me that their symptoms were way better. They started to tell me that they were have had symptoms in other parts of their body that had gone away. So I was surprised, and I said, okay, that's great. So I went to the head of my department, and I said, I think there's something here. Would it be okay if I started to see people just for this modality? Because I'm supposed to be doing it in isolation. That's kind of the thing that they say. And so she gave me the green light, and I also went to the head of the pain clinic that was referring a lot of clients to me, and I asked him if he'd start to send me some folks who have failed traditional therapy. So he started to send me really complex, more complex patients, and I started to do just Bowen work on them. And I started to get amazing results with these people. Some things, like they were going off of their pain medications, their function was significantly improving, their quality of life was really different. So I'm like, okay, it's been proven to me that something's happening, even though physiologically I'm not sure what. So I ended up going to the head of the pain clinic and said, I'd like to do an in-service for everybody and just kind of let them know about this. So I did. I in-serviced the doctors and the rehab specialists and the PTs and OTs. And so I started a Bowen clinic after I got certified, and just started to do exclusively Bowen, and my practice exploded there. I had so many patients that I couldn't see enough of them. So that's when I decided to go start my own private practice, because I realized, well, I've got this thing. And I was supposed to be the upper extremity specialist at the hospital, and they didn't really want me to see low back and leg stuff, and I had people asking me for it. So I started my own practice, which is what I'm doing today, and I have decided to become a teacher of this because I saw how profound the results were for my patients. So I went back and got the certification to be one of the instructors with the Bowen Academy. And we have since gone back to Swedish and trained 8 more people on how to do Bowen. So they have this active Bowen clinic within the rehab department. It's a first referral for many of the physicians. They'll write Bowen therapy. I see a lot of that overflow here in my clinic, people who don't want to drive downtown, people's primary care physicians from around town also. People are coming back saying it really helped me. So it's significantly grown my practice, and I have now 4 other Bowen practitioners in my office who are practicing, and actually I just hired a 5th. So I really appreciate here in the Northwest, we have many, many practitioners that are doing Bowen work, because there's other parts of the country that don't have very many people. And I think that word of mouth can be very good, because the patients are the ones who are doing the marketing. They're like, I experienced this, I want my sister to experience it, my mom and my dad. And then all of a sudden you're seeing families in your office, which is really great. So today what I want to do is just share with you a little bit about the history of Bowen work, some clinical ideas on physiology and hypothesis about really what's happening with Bowen work, and these are all just theories. There's a lot of research going on about it now, and then show you some very introductory basic moves with Bowen work and parts of procedures, so you can get a general idea of how it would fit into a clinical practice. So I'd love to have you, ask me questions along the way if anything comes up. So usually people come to me for Bowen work because they are wanting to get out of pain, and I find that is an excellent use of the modality. There's many other situations. I just had a phone call this afternoon from a woman who's having lactation problems post delivery of a baby, and there's a procedure that we do for that. So she'll be coming in the next couple days for that. But mostly we're looking at trying to stimulate and activate the body's own healing mechanism. So this is where there's a real shift in the way I'm delivering the intervention, in that I'm trusting that the body knows what it needs to do to heal itself, that I am not in charge, that I am just a facilitator of helping the body heal. And for me, that was a huge shift, because after putting all of these continuing ed courses in my bag and learning all these different techniques, I always felt well armed to go into the clinic to fix people. And trust me, I've spent hundreds of thousands of dollars doing that. And so all of a sudden, I'm being asked to actually do very minimal work on somebody and trust that the body knows how to heal itself. It took a huge leap of faith for me, and one that even after I was practicing for many years, I had to keep saying, okay, I just have to trust that this is working. And then I would see people come back and I'd hear their stories and go, phew, it did work. So I'm assisting the body in letting itself go to use its own resources for healing. And I think especially in our today's society, that's where people are running into problems, is that their nervous system isn't allowing them to heal because they're so stuck in their fight or flight response, and the sympathetic system is so charged that healing can't help. It can't happen. And so what this modality, I think, primarily is the best modality I've found to help calm the nervous system. And often what I'll do with people is I'll start them with Bowen work, with whatever condition they're coming in with, and see how far this work can take them. And often it takes them to resolution of their symptoms. If I find that it doesn't take them to resolution of symptoms, then there's always other modalities that I could try or other places I can refer them out to. But often it's just a matter of getting the system to get balanced again to allow it to heal itself. So the other area that I receive Bowen work for myself is just kind of as a preventative. So I get a lot of regular work done in Bowen work, and I find that I'm not doing it for a particular condition, but I just really, it's like, I used to go for massage once a month or once every couple of weeks, and now my choice is Bowen work. It feels better for me now. So I do have folks who come back for that treatment as well. So the way I describe it is it's a muscle and connective tissue relaxation technique that helps reset dysfunctional movement patterns and soft tissue tension patterns that are taking the system out of alignment. So that's the way I bill it. I see mostly insurance patients at my office, and I'm billing it under a neuromuscular reeducation code, because I'm changing their dysfunctional movement patterns. And what I do after the treatment is I teach them then how to move their body differently, and that they have choices in movement that they maybe didn't have before. So most of that teaching comes in the way of awareness and teaching them that they used to only be able to sit this way because their hamstrings were locked or their pelvis was misaligned, but now they have a choice of sitting like this. So increasing their proprioceptive awareness around where their body is in space is how I see this facilitates neuromuscular reeducation. So with that, then I'm also seeing a change in their structural alignment, and I'll talk more about how I think that's happening, but I think it's happening through the fascial system and the nerve endings and the proprioceptors that I'm talking to when I'm doing the treatments. It's very interesting. As I've practiced over the course of 27 years, what I am finding is that my techniques keep getting lighter and lighter. And I don't know if that's true for you too, but I am really experiencing that it's a matter of actually teaching the body how to come up into my hands versus me forcing my body down into their body. And that when I'm able to speak in a more subtle way, the body has to take note, and it has to come up and take attention. And by stimulating the nerve endings in the very superficial layer, those nerve endings are going to speak to the whole central nervous system, and they're going to speak to the visceral system and all of the other systems in the body and give them a particular instruction. And by doing that, the central nervous system responds accordingly and affects the whole body. So again, working on looking at the innate ability of the body to release its own tension patterns, that's really the key. And after practicing this for some time, it really just became clear to me that I also would limit the body's ability to heal if I felt like I was in charge. That if I am expecting a certain outcome for somebody, that may be limiting on really what their full potential is of healing. Versus if I come in and I'm providing a modality and a technique that's inviting the body to do whatever it needs to do to restore health, then kind of the sky becomes the limit. So I have had patients who have had very strong physical changes, and I've also had patients who have had very strong emotional changes, and it's affected their physiology in multiple ways. So that's what's really exciting to me, is I see that there can be a whole shift in their physiology, not only in a physical way. So the thing that's also great about it is it's really safe. It's non-invasive. You can do it over clothing, so it can be applied in any particular setting. I've done it on the edge of a sporting field. I've done it friends and family at a party. I've done it to my staff when they're, scheduling people out front, as well as being able to create an intimate setting with my client. So it's very, very versatile. It's also suitable for all clients, so all ages. I've worked on babies, and I've worked on, my oldest patient was 88. This particular technique can be really, really great for the geriatric population specifically, because it's so gentle and it's balancing the whole system. My mother is 77, and she comes in for regular Bowen work, and she says it's changed everything for her as far as her alignment, her physical energy level, her sleep patterns, and she can leave feeling rejuvenated and not feel like she's been wrung out by a massage or any other body work. So most of the sessions that I do last around 60 minutes. I tend to like to have people rest on the table for around an hour. There are other practitioners that do less procedures and are able to target certain areas of the body. I find often to get the sympathetic nervous system to really calm down, it's about a 60-minute treatment. I also usually schedule my treatments about 1 week apart. We recommend in Bowen work that you allow that time to go by to allow the body to kind of unwind, that you do a Bowen session and that there'll start to be changes that are happening in the system, but they'll continue to happen in the system day 2, day 3, day 4, all the way up into the next time they see you about a week apart. So I had a naturopath come to one of my classes as a model. She drove from Wenatchee because they don't have Bowen out in Wenatchee, and she had heard about it. And so I had her as a model here, and we worked on an old shoulder injury. And it was her first time she'd ever have Bowen. I gave her 1 session, and she came back to see me in my office. She drove back out here 2 weeks later, and she said her body continued to unwind till about day 12. And she said she was a brand new person. I mean, she cried when she left. It was really, really touching, because we could see structurally how her system was changing, and her system was really sensitive that she could feel it as well. So sometimes I have patients come in and I do a session and they go, I didn't feel a darn thing. And that's kind of how I was when I first had it. And there's other people who are like, whoa, you kind of took me to the moon and back. And so it's kind of interesting because you don't know how people are going to respond. Some people have a greater sensibility about their proprioceptive awareness, but it doesn't seem to be indicative of the effectiveness of the treatment. I see that even if your perception is that you're not feeling a change in the session, you can still have a huge change. So I tend to not know how people are going to respond. Some people will respond right away and say, wow, I feel a big change right away. And then other people can come back 7 days later and go, nope, nothing. And then I'll do another session and say, nope, nothing. And so what I usually recommend is that we try about 4 sessions, and we do them a week apart. We try not to do a bunch of other modalities, because if they're doing chiropractic, if they're doing other kinds of manipulative therapies, sometimes it clouds the water and we don't know, maybe those techniques might be intercepting and interfering with the lighter work. So if I can get people to commit to that, or at least spacing their treatments apart a little bit, where maybe I see them on a Monday, but they don't have any other therapies until a Thursday, that allows the process to at least get instilled in the body for about 3 days. But if after 4 sessions they're not feeling a big change, then I usually will refer them on to other things. And like I said, I don't know who's going to be what. Some people actually will even say that they feel like they've been hit by a truck after 1 session. And those are usually people who have a lot of chronic issues who their vitality is very low, perhaps they have an autoimmune dysfunction. And what I've learned over time is just to be very cautious. If I have somebody come in with a laundry list of problems, then I usually back way off on my session and I do very little. And usually that's a smart move, because then their body can take in the work easier and not be overwhelmed with too much information and it doesn't know what to do with it. So that's kind of taken me some practice. All right, so how Bowen work works is we use these gentle rolling moves that happen in a perpendicular direction over the muscle that we're trying to work. So it's usually what I call in my notes a cross fiber move, in that by stimulating, if I'm over a muscle, I'm going to be starting at the top of a muscle, going to the edge of it, and then going cross fiber over it. Or same thing if I'm at a tendon, I would do the same. There are little sequences within that move itself that I'll teach you about today. And then there are mandatory delays that happen after certain moves within the procedure. So we may do 3 or 4 moves in one area, and that's when we wait about 2 minutes for the body to just kind of process the work. So, as I said, it's very multidimensional, and because we're working with the nervous system is interfacing with all other systems in the body, so that's why I think all other systems can be impacted by the work. So this is Tom Bowen. This is how this technique started. He was a gentleman in Geelong, Australia, who was a layperson. He wasn't medically trained. He didn't go through any kind of schooling. By the middle of his actual practice, people started to call him an osteopath because the principles that he was applying looked very osteopathic. And there wasn't any kind of state regulations or ordinances around osteopathy within that area. He just says that this was kind of a gift that he got, and that he refined the technique by practicing different locations and working in certain sequences, and came up with kind of a system to help people. So the word started getting out about Tom. He started to work with a lot of the people at the local factory, injured workers, and he started to work with the rugby players in the area. And the story goes that he had a house that he worked out of, and that people would just line up in the morning and just wait for him, and they'd go lay on his beds and he would treat them. I don't think Tom kept people for an hour. I think he did 1 or 2 moves and they were in and out. He also didn't write anything down, and so when people came to ask him what he was doing and could he show them what he was doing, there was no written information. So at one of the massage conferences that he went to, one of the massage therapists named Ozzie Wrench approached him and said, "I want to study with you. Will you, teach me what you're doing?" And Tom agreed. So Ozzie went down to his clinic and basically just took a notepad and followed Tom around and would just look over his shoulder and look at what anatomical location he was on and what direction that Tom was moving his fingers, and then wrote that up as a procedure, and would ask Tom, why did you do that one with that person, and why did you do that with that person, and started to just create kind of a manual. So Tom worked for many, many years, and he was diabetic, and he ended up becoming an amputee, lower extremity amputee, and was in a wheelchair towards the end of his life. According to Ozzie, he wouldn't let anybody work on him. And so when he passed away, Ozzie said that Tom asked him to spread the word around the world that, to teach other people how to do this. So by the time of his passing, I think there were 4 or 5 other individuals that had started to follow him around as well. And so Ozzie took the information and formed the Bowen Academy of Australia and started to kind of create this training program with the work. The other individuals who learned from Tom, a few of them also started to create their own works related to it and called it different things. So you might hear other people call this technique other things, and I'll talk more about that. Ozzy created these manuals to have it kind of be a systematic teaching, and his teaching is a little bit different than some of the other schools that you'll run into. So he also had an affinity. This is his little niece. She had cerebral palsy. So he would see children on the weekends, no charge, and really felt like they benefited from the work. And this is a whole branch of Bowen work. We see it especially in Australia and New Zealand, working with pediatrics and working in the school district. They're working with children with all different kinds of disabilities, including learning disabilities and physical issues. But he kind of passed on that he would really like folks to donate their services to kids and as a kind of a give back to the work, which I think is really kind. So some of the offshoots that are different from the Bowen Academy of Australia is one in our area is NST, neurostructural therapy. That's taught down in the South End. And I really don't know much about it, other than it's taught, I think, in 4 days, 4 or 5 days, versus our training is 14 days. And so we tend to break it down and are a little bit more detailed. But I have had students who have done both. They've taken our training and then they've been curious and wanted to take that training, and they said it's really similar, but just not as detailed. In Ireland, there's this is Smart Bowen, and it's somebody's interpretation of the Bowen work. And in Europe, it's referred to as the Bowen technique a lot. I just went to the British Fascial Symposium in May, and there were many, many Bowen therapists, structural therapists, and physio and massage therapists talking about fascia. And Bowen work practitioners were really, really well represented, especially from the Bowen technique. So very similar work. So we started to see Bowen pop up in the United States in the early 90s. In California, I think it was in 94, was one of the first teachers that came. And it's just slowly spread throughout the country since that time. Right now there are 12 or 13 instructors in the country, so we're really lucky we actually have 3 in this area. So that's why I think we have a stronger presence, of course. There's more students here. But you may find that if you have relatives in different parts of the country, it might be hard to find a Bowen practitioner for them. So the instructors, we do a lot of traveling. And so, if there's any area of the country that people are wanting Bowen work, we're happy to do that. So we trained all different kinds of people, multidisciplinary practitioners. I just went last week to Bastyr and taught their naturopathic students this class, and going to the Bellevue Massage School in a couple weeks to teach them. We've also taught MDs, OTs, PTs, massage therapists, and acupuncturists. And that's really the nice thing about it, is I can see that anybody can do this work. It's just having your hands to do it. And it's very low cost because it's just you and the other person. So this figure of 15,000 people learning Bowen work is low. It's probably double that now. And it's practiced in over 33 countries. We've had a speaker at our last international symposium who was talking about his involvement going over to some of the war-torn African countries and teaching them how to do Bowen work in their community. And so that's what I really appreciate about this work, is that it can really be practiced anywhere. Okay, so I'm going to tell you a little bit about what the Bowen move looks like. There's actually 4 sequences to the move. The first one is that you contact the skin in a very, very light way, and we call that the glue. You're gluing your skin on their skin, and you don't want to slide at all whenever you're doing a Bowen move. So if you go ahead and place your index finger on your forearm extensors and see if you can kind of put it on the skin in a way that is as light as possible, and that you can actually move your finger from side to side and kind of take slack and move the skin, but not let the muscle layer move. So what you're trying to do is you're trying to create this underneath the skin. It's kind of a cross gliding. So that's the glue, and then that's the slack, where you just draw pressure in a perpendicular fashion just over the top of that muscle And just go as far as you can until you can't go any further and you don't want to slide. The second part of the move is that when you get to the end of that slack position, then you drop your pressure down into the edge of the muscle. And so now you're going down into the muscle belly layer, and we call that the challenge. So what we're doing is we're coming down into the muscle belly, and then we're turning our finger where we're going back in the direction that we started. So I'm kind of challenging the edge of the extensor muscle. We usually hold that challenge for about 3 seconds or so. And then while you maintain that challenge, you go back into the direction that you started, maintaining that firmer pressure. And you'll feel yourself just roll over the muscle belly itself. And then you stop when you get to the other side of the muscle belly. So the sequence is that you've got a glue, and then you have a slack, and then you drop down into a challenge, holding that for about 3 seconds, and then you make a move going back in the direction you started. Okay? So some of the theories about how and why that does anything is that you've got your epidural layer here, you've got your superficial fascial layer, and you've got your adipose layer. What goes at that site are all of these proprioceptive nerve bundles that I was talking about. There's a lot of different kinds of them. There's Ruffini endings, there's Pacinian corpuscles, there's Golgi tendon organs, there's free nerve endings. Each of them has a different role that they play within the body, and they're there to help the body sense where it is in space and to understand when light touch is being applied to it, or when stretch is being applied, or deep pressure, or any kind of movement. So if they don't have a particular role to play when there's any kind of pathology, often they'll take over and become pain receptors. So when I was at the Fascial Symposium in London, there was a discussion by Robert Schleip, who is a lead researcher in the area of fascia. And he was talking about in the area of chronic pain, what happens often is that people lose their proprioceptive ability to kind of feel where they are in space and to feel that body part. And a way to actually treat it, they're discovering, is by increasing people's proprioceptive awareness. When you increase their proprioceptive awareness, their pain levels go down. So what this study did is they took little monofilaments of different varying widths, kind of like, like a hair touching your skin, and then there was some that were a little bit thicker and a little bit thicker. And they occluded the chronic pain patient's vision and just started to apply these monofilaments and would ask them when they'd feel it. And then they would ask them where they'd feel it. And they started to do it with bigger monofilaments and then graded them down into smaller. And as they graded them down and the patient's sense perception got better, their pain levels went down, which is huge, and it has huge implications for us, I think, as manual therapists, because when people start to be able to feel what's happening in those receptors, we can really help them. And so whenever I'm working with people doing some of these light touch modalities, I will often ask them to try to bring their awareness to that particular part of their body and to kind of sense what's happening in that part versus having them zone out and disassociate with their system. So this is a typical treatment. This is what I had on the first session with the kind massage therapist who volunteered to see me. She first worked over the erector spinae at about L3, L4. And then she went down and worked on the glute maximus and medius on both sides. Then she went down into the hamstring and did a move over the tibial nerve at the base of the popliteal fossa and then into the IT band. This whole sequence with the weights took about 15 to 20 minutes. Then she came back and did the upper back and worked on my trapezius, my upper, mid, and lower trapezius, as well as the rhomboid major and minor, and into the levator. And that took another 15, 20 minutes. And then she came up and turned me over and worked on my neck and did my scalings, both the posterior and middle scalings, up into the occiput, and then at the erector spinae, kind of mid-neck. So this is what we call the basic balancing moves. Today I'm going to teach you a little bit out of this procedure, a little bit out of this one, a little bit out of this one, and a little out of a couple others, just so you can get a sense of kind of what that would be like to have the procedure done. But this is what you'd learn in Module 1. So at the end of Module 1, you'll know how to do a full session, and you'll also know how to work on the kidney area, as well as we do a procedure on the head, which is really nice. So a couple different theories about the physiologic mechanisms about how Bowen works. There's lots of different ideas. I think a lot of it comes down to where your lens is and where your training is and how you could fit this model into what you understand. At least that's what it's been for me. I find that my model has always been fascia and muscles, and so when I'm working with somebody, I'm thinking along those lines and I'm watching how this treatment is affecting that. There used to be an acupuncturist that was one of our teachers, and he looked at it from the viewpoint of meridians and would see that when we were doing certain moves, we were affecting certain meridians. So, I think that's kind of true in all of medicine. We don't really know how things are working, but we have a general idea, and we could all be right, right? They could all be right. So part of it is rebalancing the autonomic nervous system. As we know, it's part of the sensory system, it's part of the peripheral nervous system, and that it's composed of the sympathetic and parasympathetic. So sympathetic is the fight or flight, parasympathetic is more of the rest and digest. And so we need both of those systems to survive, and this is a matter of us trying to regulate it and balance it. So many of these moves are done right along the sympathetic ganglion chain. So if you look at the body in the thoracic region, we have a sympathetic chain that goes all along the edges of the paraspinals there, underneath the paraspinals. And that sympathetic chain is connected to the whole system. So I'll show you in the next slide, but we're going to be innervating and influencing the cardiac system, the digestive system, the pulmonary functioning, all systems, the hormonal endocrine system, by stimulating those areas. So many times when I am in the process of working on somebody and I'm right in the mid-back and working up into their lats, usually that's where I start to feel people really sink in with the work and they start to become really, really relaxed. And often people will fall asleep in a treatment during that time. So this is a nice schematic of what that sympathetic ganglion looks like. And we need to have it operating in both directions. So we need the parasympathetic system to be able to slow things down when we need it slowed down. We need it to slow our heartbeat. We need it to allow the digestive system to function correctly. We need it for our bladder function. And then the opposite, when we need things to speed up, then we need them to speed up. And I know in my practice what I've seen a lot with individuals is they'll start to have some chronic musculoskeletal condition, and then they'll start to tell me about all these other cascading things that are happening with them, like, I used to not be sensitive to dairy and to wheat and all these things, and now my digestive system's a mess, or I used to not have thyroid problems or other hormonal issues, and now that I've had this car accident, like there's this whole thing that's happening. Or now I don't sleep anymore, and I used to sleep, and now this is all messed up. Have you guys experienced that with your clients? And it's because this system has become so dysregulated that all of those other systems are going wacky. And the problem is our Western medicine society has specialists for each of these areas, and unfortunately, usually our specialists are using pharmacologic intervention, and so then those medicines are counteracting other things that would allow the body to heal. So that's where it's been really refreshing to have hands-on manual treatments that we can affect all of these systems and be able to help people get better. So, I think the whole concept of disease is having those systems dysregulated. And while we can work on them to try to help their physical discomfort, we can also facilitate all of these things coming back into balance again. All right, so we've talked a little bit about the body's own facilitated repair mechanism. Another option or another discussion area around what's really happening with Bowen work is around the stimulation of these proprioceptors and stimulation of the nervous system. As I mentioned, we have different nerve endings that are going to stimulate different parts of the body, and that when we do stimulate them, a message is sent directly up into the cerebral cortex and into the spinal cord itself. And changes can happen both in the spinal column and in the somatosensory cortex and make those changes. I think this is why the 2 minutes are really important, is that you can have this stimulation down here, and it takes around 2 minutes for the message to go through the spinal column, up into the motor cortex, and then come back down into the periphery to really let the body know that it can reset those tension patterns or can alter how the system is set up there. So with that, what I end up seeing a lot is that people will stand up and just say, I feel really relaxed, A, and B, that, wow, I've got a lot more range in my shoulder, or I can feel my hips can really move now, or my back pain is gone. So this is just kind of a schematic of what happens when we have any kind of spinal reflexes happening. And you can see how this one will just travel to the spinal column itself, and other messages will go up to the cerebral cortex. This is where I really have an interest in an area of study and have been doing a lot of experimentation around objective testing of fascia. I do a technique called myofascial length testing, and it was developed by my teacher at the Institute of Structural Medicine, where you can test out the fascial lines and test out specifically within the line where the greatest restriction is. And what I do a lot with my Bowen clients is I will test them. I'll do a postural analysis in standing, and I'll do myofascial length testing to see where they're most limited. And then I apply the Bowen moves to where the structures has the greatest restriction, and then I retest them after treatment, and they significantly change. And so being able to give the client that feedback of, can you see how this actually really changed, instead of just waiting for them to tell me, do you feel better? Do you feel better? It helps me both insurance-wise, because I can document, okay, this person had 90 degrees of latissimus dorsi length when I started. After my Bowen treatment, they were at 160. That holds a lot of merit. And then I can show the client, too, use that as a neuromuscular re-education piece of, okay, when you first came in to see me, you really shouldn't go up into your cupboard to get that thing because you didn't really have the range, but now you do after the session, and now you're safe to do this. Or if I didn't get a change, I can explain to them about kind of where their safe zone is for their functional movement. So you guys are familiar with anatomy trains? Excellent. Okay, so I'm always thinking about three-dimensional balance within the body. So if I have somebody who has a shoulder pathology, I'm looking at the relationship of that shoulder and how it relates to the hip and how it relates to the base of support in the feet. So I had a nurse at Harborview who came to see me. She had a frozen shoulder a couple months ago, and she had gone to traditional therapy. She had had a lot of physical therapy, and she still was in quite a bit of pain. She was having a lot of range of motion restrictions and pain with sleep and with her function. And so as I analyzed her, I could see that she had a lot of asymmetries in her hips, and therefore she had a lot of changes in her pattern of standing in her legs. And she said, oh yeah, I had this labral tear on she had a left shoulder problem. She said, I had a labral tear on my right side, and but yeah, I'll deal with that after my shoulder's better. And I said, you know, we really need to balance your structure out to get your shoulder better. And so I did some Bowen procedures on her that looked at the line and balanced out her hip, and her frozen shoulder went away. So you guys probably already understand that concept, but for the Western medicine allopathic world, that's kind of rocks their world, that you would have another body part be able to influence. But that's what I found with Bowen work that is so good, is that I'm treating the whole body globally, and by applying these moves globally, I can get rid of so many conditions so quickly. So again, what I really see happening is we allow the gluing to open up, and so often what it feels like in the tissue is that there's not the ability for the fascial system to have the gliding where it needs to have the gliding. And I also see that there can be a lot of twisting that happens in the connective tissue. So where if I can take the tension pattern out where the greatest restriction is of that twisting, then often the whole line will unwind or that whole limb will unwind. And by combining analysis and testing with Bowen work, it's really amazing what we can do. So we talked about the mandatory delay then. Kind of interesting, if you are familiar with strain counter-strain, Lawrence Jones developed the technique. His was similar in that he would put the tissue in a shortened position and apply light pressure, and then he'd wait about 90 seconds. And so he did some studies where they took EMG studies and looked at how long it did take for a tissue to just kind of give it up and let go. And it was around that time. So when I see studies that can overlap and cross over around different theories, it makes me feel like, yeah, we're kind of on the right track here. So I have a video I'd like to show you of a naturopath and the way that she practices Bowen work. I may actually have to show you after I get my internet back up. So for review, that Bowen work is very safe, very gentle. There's really no contraindications for its usage. There's one procedure that we avoid doing on pregnant women because it can induce labor, but otherwise there's no other precautions at all. And it's kind of interesting, when I first learned about it, there was all these different things I'd see on the internet about what it can be used for, and I always get suspicious when there's like a gazillion indications for use, you know? But then as I started to practice, I'm like, you know what? It kind of works that way. Because we're working on this nervous system, and because that affects other systems, I can start to understand how there can be so many different things that can happen as far as restoring balance in the system again. One of the biggest areas I have found that it's helpful for are my fibromyalgia patients. And Lyme's disease and chronic fatigue syndrome, those kinds of issues, and autoimmune dysfunctions like Sjogren's or rheumatologic issues, because the system is kind of attacking itself in many cases, and because the vitality is so low with many of those clients, they can't handle the heavier work. So it's a nice light technique that they can slowly resolve. I had a client who was a social worker who became debilitated after the stress of her job, and she ended up developing severe fibromyalgia. She came to my clinic and she literally looked like she was going to die. She was very, very thin, and she could barely walk into the office. But she'd heard about Bowen work and wanted to try it, and so we set it up. She couldn't even handle the contact of my sheets on her skin, so she'd bring in her own bedding, and it would take her about 20 minutes to set it up. She had an assistant that would come with her, and she could only lay on her back, so I modified the technique where I would gently slide underneath her sheet and then be able to do the move on her skin. And I saw her for probably 6 months, and she said it had been the only thing that helped her be able to improve her endurance and increase her sleep and her digestion, her mood, and she was able to start a walking program and be able to start a very lightweight program. So I was able to see her for many months before her insurance ran out, unfortunately, but hopefully I'll get to see her again in the new calendar year. But cases like that I don't know what else she could have done, and it was really gratifying to see that we could offer her something. So this is just some of the clinical research that's out there. There's not a lot. There's a lot ongoing. I went to the International Fascial Symposium up in Vancouver in 2012, and there was poster presentation on Bowen work there, and there were a number of Bowen practitioners that I ran into. I am anticipating at the Washington, D.C. Fascial Symposium we'll see some more. I'm submitting some abstracts to that conference. But probably the recent one I've seen is the effects of Bowen work on hamstring flexibility. Really simple study, looked at hamstring length, did Bowen work, looked at hamstring length, significant improvement. We see those every day in our clinic, but it's just a matter of getting the evidence-based medicine written up in studies and put in the medical journals. There are some protocols for headaches and migraines, which have been really helpful for many of my clients. Frozen shoulder has been huge. I see a lot of resolution with lateral epicondylitis and carpal tunnel kinds of stuff, as well as low back pain. So for me, I see that I'm really, really interested in changing healthcare in the way that we deliver and look at individuals, both from a full physical, whole body kind of look, as well as a mind-body perspective. And I feel like we're very far away from that in our allopathic way of teaching now, and that with this kind of work, as well as other works that are out there, this allows us to really be looking at the whole person and their mind and their body. And I also see how this can help promote wellness instead of looking at waiting until people have severe pathology before we treat them, that people could come in and receive care as a preventative as well as for any kind of condition that they might have. We currently offer a community Bowen work clinic here in this studio, and we have a practitioner once a week who sets up these tables, and it's just pay as you go. It's modeled after community acupuncture, so you can come in just signing up online. About every 15 minutes a client can come in and just receive a Bowen session in a group setting. And I think she charges she recommends a charge of anywhere between $20 and $40. And she also will see people for free if they can't pay. So it's a nice way of being able to promote a service, and it can be low cost. So I've had patients whose their insurance has run out, they can come to community Bowen work. We've also offered some community Bowen work through some health fairs, and have even gone into people's workplace and provided kind of a workplace wellness kind of situation. All right, so that is the presentation on Bowen work. So what I'd like to do next is I'd like to take a break, and then I'll show you a little bit about how to do the moves, and we can start practicing. What I'm going to have us practice is the way to make a Bowen move. So remember how I talked about kind of gluing your fingers on the skin. There's two different kinds of moves that you can do in Bowen work. One of the ways is through what's called a goalpost position. And this goalpost position is kind of what we call the classic move. So this first move is done just one finger width above the crest of the iliac spine, or iliac crest of the pelvis. And we're going by the client's finger width. We're positioning the thumbs right at the apex of the highest point of the erector spinae group here on the side of the spine. The first step to this is I'm going to glue my thumbs just very gently on top of the skin surface. I'm going to slack towards me, just taking that superficial epidural layer and superficial fascial layer as far as I can towards me. I'm then going to challenge down into the body and hold this challenge for around 3 seconds or till the client takes a nice good breath. And then at the end of the exhalation is when I'll make the move. So I'll move towards the spine, maintaining that pressure, just gently lifting my wrist while maintaining the pressure all the way towards the other side of the erector spinae group. I'm then going to release my thumbs, come across to the other side of the body, use the V position with my index fingers. Again, starting on the apex of the erector group, slacking away from the spine, challenging on the edge of the muscle group there by bending the tip of my index finger and slightly challenging towards me. Again, waiting for 3 seconds and have the client exhale. And at the end of the exhalation, I'll maintain that pressure as I move my index fingers back towards the spine, flattening the tips of the fingers to complete the move. So we have the positions of the moves. I showed you the classic move, which is using the goalpost and the V on page 9 and 10 and 11. And we're pretty standard with those. Depending on where we are at, sometimes when we're down into the ankle, or we even have procedures that you work into the jaw, there'll be a lot of variations to these particular techniques, but most of the spine and into the bigger parts of the body will use the goalpost and the V. We talked about the classic move involving the slack, the sink, the challenge, and the roll, which we just practiced. And then we showed you the low back procedure. If I go to page 27, just a way for you to read this manual. The way that we've shown how to do the move is by using the arrows, and the arrows can show you which direction to go, and the white circle shows you where you start. So that's where you put your hand placement. The dotted line with the small arrow is showing you how you take slack, and then the black arrows is showing you the direction of the actual move itself. So if you go on to page 29, you can see on primal pictures that you'd start in the center of the paraspinals, moves 1 and 2. This is the move we just did. You slack medially, you challenge at the edge, and then you make the move medial, starting on the left side and then going to the right. So, like I said, in Bowen work, we tend to stand on the left side for most of the procedures. When people have asked why and asked Ozzy why, the left side, he talked about, tends to be the more receptive side, which we sometimes talk about in massage work, of the feminine and the masculine sides of the body. Okay, so now we're on page 34. We're going to the upper back, moves 1 and 4. This is, we call this the emergency move. So whenever there's somebody who has just suffered an injury, we tend to do these moves 1 through 4. So this is for the upper back procedure, these first 4 moves. These are also called the upper back stoppers. Where we identify the location of these is by identifying the inferior border of the scapula with our middle finger. Now, if it's difficult for you to identify on your client, you can always ask the client to bring their hand behind their back, or you can passively bring it there to just have that inferior border slightly pop out, and then they can rest back into their resting position. So after you've identified that inferior border, you can draw an imaginary line across the body. Where the index finger lands is where the move 1 is going to be performed. Move 2 will be directly across from that. Move 3 will be done 1 finger width up from that first move, where the ring finger landed, and then move 4 will be directly across. So what I'm going to do is I'm going to go ahead and assume that goalpost position, right where that index finger landed, at the highest point of the erector group. I'm gently relaxing my fingers, gluing onto the skin surface, slacking towards me, challenging down into the edge of the muscle by dropping my wrists, slightly angling my thumbs towards the midline, waiting for the exhalation. At the end of exhalation, I'm going to maintain my pressure and just gently lift my wrists up and over that muscle group. I'm then going to come across the body in a V position, perform the same sequencing where I'm going to take slack, challenge on the edge of the muscle by lifting my index finger, or lifting my wrists and bending the tip of my index finger, waiting for the exhalation, and making a medial move. Then I'll be moving 1 finger width up where my ring finger landed, and doing the same sequence with the goalpost positioning, slacking towards me, challenging onto the edge of the erector group, waiting for that exhalation, lifting my wrists while I maintain that pressure up and over. Same thing with the V position, slacking away, challenging, holding for a minimum of 3 seconds, end of exhalation, making that move towards the spine. So that's the upper back stoppers, moves 1 through 4. The respiratory procedure. So this is a really, really good one. This is one that we do on the front of the transverse abdominis and into the edges of transverse abdominis and the obliques, and then right at the center of the start of rectus abdominis. So this one can be super effective, again, like I said, for more respiratory kinds of issues, but also for any GI issues. So I often will actually just do these 3 moves on myself if I'm feeling like, oh, I'm kind of having some indigestion and I haven't really settled very well. You can do these 3 on yourself. So this next move is moves 3 through 5 of the respiratory procedure. The first 3 moves are done on the back of the body, and then the moves 3 through 5 are here on the supine aspect. The first place that we're going to be identifying is the holding point by using the superior hand. I'm going to be identifying the xiphoid process and coming just distal to that in the soft tissue hollow here. I'm using my superior hand with my palm facing the head, and I'm applying very, very light pressure. It's about a pressure 1, meaning that I'm just touching the skin surface and not going down into any of the musculature. I'm then identifying the bottom of the rib cage, and I want to come halfway up from the base of the rib cage to my holding point on the edge of the rib cage itself. I'll find myself right on the edge of the rectus abdominis. I'm going to be pointing my thumb towards the holding point. My movement is going to be in a superior medial direction, and I'm going to be coordinating this with the timing of my client's breath. So I'm going to have my client just take some nice, good breaths, and I always want to make these moves on the exhalation. So I'm slacking up on the exhale. I'm going to wait for another exhale to make the move. I'm slightly challenging into the edge of the rib cage, and then at the end of exhalation, making an inferior lateral move. Releasing that pressure, coming over to the other side of the body, doing the same movement, except this time with my middle finger. So I'm halfway up from the base of the rib cage to my holding point. I'm on the edge of the rib cage. I'm slacking up towards my holding point on the exhalation. And at the end of exhalation, making an inferior lateral move, angling just on the edge of the rib cage, trying to affect the diaphragm. The last move is going to be done just distal to the holding point. I'm going to use my middle finger of my inferior hand. I'm going to remove that holding point. The slack will be done on the exhale up towards the head, challenge very lightly, and on the exhalation, make an inferior move. And I'll show you these moves that we do on the edges of the patella to affect the vastus lateralis, and then the underside of the patella, and then vastus medialis. That's what we'll cover tonight. We also go back in for the rest of the procedure and move all the way down the gastroc. So we go all the way down the gastroc into the Achilles tendon, and then we work on the sides of the gastroc, and then we work down into the neurovascular bundle down here and affect some of that deep line. If you remember the Tom, Dick, and Harry tendons there, and then the nerve that goes right underneath there. So I found this procedure to be incredibly helpful for many conditions related to hips and knees and anything related to lymphatic flow in the leg. So this is the knee procedure. This is the beginning of the knee procedures, moves 1 through 4. It begins by identifying the 4 corners of the patella by using your index finger and your thumb, finding just the edges of the small region of the patellar bone. Where your superior thumb lands is where the first move is going to be done. So find that location, move your lower thumb up to meet your upper thumb. You're going to be right on the edge of the vastus lateralis, right on the top portion of it. You're going to be doing the classic move where you glue, you slack down towards the table, challenge underneath where you're feeling just the underside edge of the vastus lateralis. You're going to start your challenge and make this move very slow. I usually count to about 8 as I'm coming up and over the vastus lateralis. And you should feel a very distinct movement of the vastus lateralis that'll come underneath your thumbs. So for the second move of the knee, then, you want to find that inferior border of the patella. You're going to be using the tip of your index finger You'll take slack in an inferior medial direction, coming just on the underside of the patella, and make a move in a superior medial direction. Return back to center. The third move is going to be done with the thumb in the same general direction. You're going to be going inferior and medial for your slack. Challenge just on the edge and underside of that patella, and make a move up and out. And that is move 3. So for move 4 of the knee procedure, it's done by identifying the superior aspect of the patella with your ring finger. You're using 3 fingers as a spacer. You're going to come down to the medial midline of the leg where the pant seam would be, and you'll find your fingers on the edge of vastus medialis. So where your index finger lands is where the move's going to be done. You'll meet your index fingers, bringing them together. Again, gluing, slacking down towards the table, challenging the tips of those fingers under the vastus medialis, and then slowly coming up and over the top of the edge of vastus medialis for move 4 of the knee procedure. Okay. So this is an example of a flat move. This would be done over a region of the body that we're not addressing a particular muscle belly itself, but we're addressing something that is a little bit more of a kind of two-dimensional surface. So for instance, we're on the IT band right now, and you can see I'm kind of on the middle portion of the IT band. So instead of making the move where I'm slacking and then I'm challenging on the underside, this is actually called a flat move. So I'm going to glue, slack down, and I'm just going to apply gentle pressure in towards the leg, and then my move itself is just going to be following as much of the fibers perpendicularly as possible over the IT band. So this one can be done in sitting or laying down, and any kind of neck restrictions. So we're going to be affecting splenius capitis, splenius cervicis, but also the trapezius and all of the structures below that. And these moves are done kind of halfway point, halfway between the attachment of the lower ear and the top of the shoulder. So I think I'll show you in sitting first, just so you can kind of see where the position is. So this is move 5 and 6 of the neck procedure. This can be done in sitting or supine. We most usually do it at the end of a Bowen session and the patient continues to be supine, but I'm going to show you in sitting for demonstration purposes so you can see the anatomical landmarks. So where I'm finding them is I'm finding the top of the shoulder and the base of the skull here, and going midway to right around C3-4, and I'm identifying the spinal extenders here, so the splenius capitis, cervicis, the upper trapezius, and I want to start with my middle finger on the highest point on the left side of the head of the neck. So I'm going to be using my middle finger. I'm going to be taking slack laterally, challenging to the edge of that muscle group, bending the tip of my finger, and again I like to do this move slow, just so I really get all of those fibers as I go ahead and challenge and make the move towards the midline of the neck. And I'm coming up and over those structures. I'll be doing the same thing on the other side. I can be using my other hand if the client's in sitting to stabilize at the forehead. Again, slacking, challenging with the tip of my finger, and slowly making a move towards the midline. Now this move can be repeated if there's tension, and we often do that, calling it moves 7 and 8 of the neck procedure. Okay, so I want to thank everybody for coming to the Introduction to Bowen Work class. It's been really awesome to have you all, and I look forward to seeing you hopefully in our upcoming modules.